Anxiety Disorders by Group 2.
Obsessive compulsive disorder is an anxiety disorder characterized by uncontrollable, unwanted thoughts, which may lead to repetitive behaviors to try to ease the anxiety. In the next 3 slides, we will go over the etiology, symptoms, and basic medical treatment needed for patients who are suffering with this chronic disorder. There's not one definitive cause of OCD. However, there are several factors that are likely to cause patients to have OCD. Some of these factors include neurobiological factors, genetic, behavioral, cognitive, and environmental factors, to name a few. Brain imaging technologies have found that areas in the brain that seem to cause OCD are generally abnormalities in the neurotransmitter system chemicals, such as serotonin, dopamine, and glutamine, which may be some that are involved, creating problems with sending messages between brain cells. In fact, there may be a mutation in the human serotonin transporter gene in people with OCD. OCD may also be a learned response, according to learning theorists. They believe that people who are having anxiety with their obsessions learn the compulsive behaviors to cope with the anxieties from the obsessions. Cognitive therapists believe a little bit different of a theory, and that is that their obsessive thoughts are actually the dysfunctional part of the OCD, and they're what is causing the distress. And compulsive behavior is used to avoid the obsessive thoughts, so that to try to get rid of the obsessive thoughts, but not necessarily the anxiety. Of course, environmental factors would play a role, such as how a child was raised, any child abuse, the way somebody might deal with stress, for example, and how a person can handle stress. There are other things like bacterial and viral infections that have been thought to cause the onset of a child getting OCD. Genetic factors have been thought to have an increase in whether a person develops OCD. There have been twin studies where usually if one twin develops an OCD pattern, the other twin also will. OCD is also not attributed to the use of drugs or other substances like alcohol. Also, one thing that's kind of interesting is that other kinds of anxiety disorders might cause an increase in a patient getting OCD. Patients with OCD can have obsessions or compulsions or both. Obsessions are defined as a repeated thoughts, urges, or mental images that can cause anxiety. Compulsions are defined as repetitive behaviors that a person with OCD feels the urge to do in response to an obsession. People with OCD are aware of their obsessions and compulsions, and this awareness causes anxiety. This is different than that OCD personality disorder or obsessive compulsive personality disorder. And these are two distinct, different diagnoses. So, do you think that you have OCD? Some people do, but when people obsess over things and have compulsions, it doesn't necessarily mean that they have OCD. For somebody to have true OCD, a person usually spends over an hour, much more than an hour, on their thoughts and behaviors. They're unable to control their thoughts and behaviors, and they are feeling a bit of a relief from the obsessions by performing the compulsive acts. And it will cause severe anxiety related. On this screen, I have signs and symptoms of OCD, and I'll let you go ahead and read through that on your own.
Treatment of OCD. First, we have behavior therapy. There's systemic desensitization, where the patient is gradually exposed to the thing that they're afraid of. And we have implosion therapy, also called flooding. These are both done with a therapist. Cognitive therapy is a highly structured short-term therapy. It lasts 12 to 6 weeks. All 5 goals of the cognitive therapy are in Chapter 19 of the Townsend book. Psychotherapy is when a psychotherapist uses logic and rationale to increase the patient's understanding about the situation that's causing them anxiety. And then we have medications. There's anti-anxiety drugs. These produce a calming effect in the brain. And then SSRI antidepressants have been approved to treat OCD.
Next, we'll take a look at the etiology, symptoms, and basic medical treatment for post-traumatic stress disorder.
So for the etiology of PTSD, you can get it through natural or man-made disasters, combat, serious accidents, witnessing the violent death of others, being the victim of torture, terrorism, or rape, or being the victim of other crimes. Some risk factors are living through dangerous events and traumas, having little to no social support after the event, childhood trauma, and having a history of mental illness or substance abuse. So for the signs and symptoms of PTSD, not everyone with PTSD has been through a dangerous event. You can get it from maybe experiencing a sudden death of a loved one. The symptoms usually begin early, within 3 months of the event, but sometimes they begin years afterwards. Symptoms must last more than 1 month and be severe enough to interfere with relationships and work. With the re-experiencing symptoms, flashbacks are reliving the trauma over and over, including physical symptoms like a racing heartbeat or sweating. Re-experiencing symptoms may cause problems in a person's everyday routine. Words, objects, or situations that are reminders of the event can also trigger these symptoms. With avoidance symptoms, they may stay away from places, events, or objects that are reminders of the trauma or experience, avoiding thoughts and feelings related to the traumatic event, and these symptoms may cause a person to change his or her personal routine. Like after a bad car accident, a person who usually drives a car may avoid driving or riding in the car. Arousal and reactivity symptoms are usually constant instead of being triggered by things that remind one of the traumatic events. These symptoms can make a person feel stressed and angry. It may make it hard for you to do daily tasks like sleeping, eating, and concentrating. And cognition and mood symptoms, they're distorted feelings like guilt or blame. Cognition and mood symptoms can begin or worsen after the traumatic event, but are not due to injury or substance abuse. These symptoms can make the person feel alienated or detached from friends and family.
For the treatment of PTSD, we have psychosocial therapies like cognitive therapy, prolonged exposure therapy, group and family therapy, and eye movement desensitization and reprocessing. For psychopharmacological therapies, we have SSRIs, which are the first-line treatment of choice for PTSD because of their efficiency, tolerability, and safety rating. We have other antidepressants like trazodone, tricyclic amitriptyline, and imipramine, and MAOIs. Benzodiazepines are sometimes prescribed for their anti-panic effects, although their addictive properties make them less desirable. Antihypertensives are sometimes used, like propranolol and clonidine, because they have been successful in alleviating symptoms such as nightmares, intrusive recollection, hypervigilance and insomnia, startle response, and angry outbursts. Ketamine infusions in combination with psychotherapy have demonstrated effectiveness in recent years as well. Complementary therapies that can treat PTSD are acupuncture, pet therapy, relaxation therapy, and hypnosis. They've been helpful in alleviating some of the symptoms of PTSD.
Lastly, we'll look at the etiology, symptoms, and basic medical treatment involved in acute stress disorder.
The immediate cause of acute stress disorder is exposure to trauma. The trauma is noted as being a stressful, non-typical life event, which can be described as horrifying or terrifying. Trauma has both medical and psychiatric definitions. Medically, trauma refers to a serious or critical bodily injury, wound, or shock. Trauma in psychiatry refers to an experience that is emotionally painful, distressing, or shocking, often resulting in lasting mental and physical effects. It is very similar to PTSD. However, it was distinguished from PTSD in 1994 when it was added to the 4th edition of the Diagnostic and Statistical Manual of Mental Disorders. In PTSD, the full symptom picture must be present for more than 1 month and cause significant interference with social, occupational, and other areas of functioning, whereas with acute stress disorder, the symptoms last for at least 3 days, but not more than 1 month. However, if left untreated, acute stress disorder may turn into PTSD. Individuals may be at a greater risk for developing acute stress disorder if they have previously been diagnosed with a mental disorder, if they perceive the traumatic event to be very severe, have an avoidant coping style when experiencing distress, or have a history of previous trauma. People who were abused or experienced trauma as a child are more likely to develop because these may produce long-lasting biochemical changes. There is a biological vulnerability. The hypothalamic pituitary adrenal axis, or HPA axis, is our central stress response system. Dysregulations of this axis are associated with several psychiatric disorders. Disorders such as PTSD and ASD are associated with diminished HPA activity. Women are more likely to develop the disorder than men. Older adults are less likely to develop the disorder because they have had more experience coping with stressful or painful life events. People who have a close network of friends and family are less likely to develop ASD. And finally, people who feel inappropriate responsibility for the trauma, regard the event as punishment for personal wrongdoing, or have a general negative or pessimistic worldview are more likely to develop ASD than those who do not personalize the trauma or are able to maintain a balanced view of life.
To sum it up, the signs and symptoms for acute stress disorder include recurring memories, dreams, or experiencing flashbacks of the trauma that caused someone to have an acute stress disorder, having a hard time to experience happiness or other positive emotions like satisfaction or love, taking any opportunity to withdraw oneself from being around things that could possibly remind them of his or her trauma, and lastly, sleep problems, which include having problems falling asleep, or having problems staying asleep.
When treating acute stress disorder, you have a few options: cognitive therapy, prolonged exposure therapy, group and family therapy, eye movement desensitization and reprocessing, and pharmacological interventions. The goal of cognitive therapy is essentially to reprogram the brain. The goal is to replace negative thoughts about traumatic stimuli with more accurate and less distressing thoughts so that you can cope more effectively. When a stimulus is presented that usually triggers feelings of anger, guilt, and fear, the goal is to appraise yourself and the world around you and evaluate those feelings to determine their validity. The goal is to replace those feelings with a more of an optimistic view of them, to reinforce feelings of safety and trust and power over the situation, self-esteem, and intimacy. Prolonged exposure therapy has four main parts. The first is education about the treatment. The therapist has to inform the patient that this is going to be a very emotionally intense process. You're essentially going to be reliving your trauma. The second part is breathing retraining for relaxation. Think about our square breathing that we learned in first quarter, how calming and how grounding that was. Third is the imagined exposure through repeated discussion about the trauma with a therapist. You'll discuss the traumatic event itself, the feelings that you experience, and really kind of hash out the emotions involved. Fourth is the exposure to real-world situations related to the trauma. Now, this can be done through a virtual reality simulation, or it can be done systematically in a real-world situation. And I say systematically because you want to confront the situation with safe limitations, because this can be very overwhelming for the patient. Eye movement desensitization and reprocessing, or EMDR, is contraindicated for clients who have neurological impairments like seizure disorders, clients who are suicidal or experiencing psychosis, those with severe dissociative disorders or unstable substance abuse, and those with detached retina or glaucoma. During phase 1, the therapist takes a thorough history and develops a treatment plan. This does not involve discussing the details of the traumatic event itself, but more focuses on the emotions and the feelings around the event. Phase 2 is essentially a trust-building phase. It's essential that the therapist and client have a very trusting relationship during this treatment, so the therapist will recommend a lot of self-care techniques and really encourage the patient to recharge their batteries in between sessions. In phase 3, the client identifies a specific scene or a picture that accurately represents their traumatic memory. They're asked to express a negative self-belief that's associated with the memory. For example, I am bad or I am in danger. And they're asked to replace that with a statement that they would rather believe, something like I am good or I am safe now. The client then rates those statements on a scale of 1 to 7 for validity to determine how true they feel the statements are, and a scale of 0 to 10 to determine how disturbing they find the statements to be. During Phase 4, the client pays attention to their negative beliefs and disturbing emotions around their traumatic event, while also focusing their eyes on the back and forth motion of the therapist's finger. All of the feelings and physical reactions they experience are noted. These rapid eye movement sessions are repeated until the client self-reports their level of distress to be a 0. During Phase 5, these rapid eye movement sessions are repeated with the positive self-statements they identified earlier, and then the patient self-reports the level of validity of those statements until they believe them to be a 7 out of 7. During Phase 6, the client discusses the traumatic event and does not move on to Phase 7 until they can discuss the traumatic event without feeling any bodily tension. During Phase 7, the client is instructed to keep a journal of any negative thoughts or feelings about this traumatic event that may arise in between continuing therapy sessions. And finally, Phase 8. Re-evaluation begins each new therapy session. The therapist assesses whether or not the positive changes have been adequately maintained. For pharmacological interventions, SSRIs have become the first drug of choice for treating trauma disorders like PTSD or ASD because of their efficacy, tolerability, and their safety ratings. Other drug classes include anxiolytics, antihypertensives, and other medications like carbamazepine, valproic acid, and lithium carbonate.